So Bill, this is always so tough for docs, and the answer with at least the oncology care model has been to make the treating physician more responsible in some way for the global cost of care. And although you're a doc in a major institution, academic institution, you may not be personally feeling that impact as you would in a private practice that's in the OCN model, but you're well aware of this movement toward somehow physicians being responsible for the total cost of care. And I'm curious, in a value-based care world, if you might be willing to opine for a minute or so on that.
Yeah, well, you're correct. We are somewhat shielded from that in the kind of institution we work, a big university. But that said, we're still cognizant of the choices we're making. And as someone who oversees the women's health, the cancer program, if somebody is trying to create some treatment regimen that nobody's heard of, they all come to me, that comes to me for approval or not. And that becomes more common, as you know, as we get into this era of quote unquote precision medicine, where if you get a molecular test, you make up something because there's oftentimes no data to support it, and you're asking for approval for something that is clearly not one of the indications for that drug. So that's not an uncommon phenomena from that perspective. I think that as a community, we're starting to more broadly look at how we judge the efficacy of therapy, not only in terms of clinical endpoints, but cost. For instance, the NCCN, as crude as they might be viewed in some respects, the evidence blocks are an effort to take into account not only clinical benefit and toxicity, but also cost as part of that. And we haven't really, legislated that one thing should be over the other based on cost. That's not the mandate, say, of the NCCN. But I think it is something that we're inevitably going to have to confront, because the costs, which we've been saying for years and years and years, are out of hand. And as new drugs come on board, and many are coming, that's a great thing. It's just inevitable that the costs are going to outstrip our resources. So I think as a community, at some point, we're going to have to confront this head on.
So Joyce, how close do you think we are to having to have that confrontation? And in the current environment of the pandemic, it just feels to me that it's escalated that conversation. And from something that you feel like it's just going to be heightened in every election cycle, and then it's going to go back to a back burner. And it just feels that now in the current environment, something's going to happen sooner than later.
What do you mean, Bruce? Are you talking about a single payer system, or?
Well, whatever that may be, but it feels like the current model's not working. And what I heard from Kelly is that, it's literally month to month. What I heard from Steve is it's complicated and there's no perfect solution, and payers are struggling with it as much as patients are struggling with it. And, Bill has weighed in that it's imperfect design, and that efforts like NCCN try to increase the awareness. They've moved to preferred regimens and not just levels of evidence. So you don't just have 12 level 1 evidence regimens to choose from, but 2 or 3 stand out. And so I'm curious if you think that we're going to be moving sooner than later, whether it is universal coverage, a single payer, but are you kind of more of the pessimist that it's going to be more of the same, we're going to continue to struggle with this, or if you think that there's something more definitive that's going to happen in the shorter term?
I agree that the current situation is not likely to persist indefinitely. I'll tell you, when I have to do 2 to 3 peer-to-peers to get something approved for my patient, and let me tell you, well, as we all know, the process is very, very challenging. And I often, of course, will ask to speak to an oncologist as a peer-to-peer, but sometimes it's not available. But just the whole process. I had an example yesterday, even just the process. People are trying the best, at our practice to navigate me onto the right telephone call and everything. But I'm trying to get a brain CT for a patient of mine. It's not even that expensive in the scheme of the things that are expensive in medicine. And so far, I've had 2 peer-to-peers, and I haven't talked to the right person yet. and so anyway, it's so complicated. Everybody's trying their best, I think, but everybody has their own rules to go by. So I think it's just become complex to a level that's unsustainable in terms of just us accessing things. You know, I'll tell you where I put my hope, and that is that our big EMRs that allow us to really understand cost of caring for populations. I'm hopeful that, and this is, I think, where the OCM is moving, that, let's say that 80% of care is, just absolutely on guidelines. It's, kind of very predictable. We know the median time on treatment, we know the cost. So we got 80%, fine. You can budget for that. You can look at all the imaging. I think we over image, we can cut back on imaging, et cetera. So I think 80% we can, okay. But then, there's always that 20%, but you have to budget for that. And as Steve said, there's off-label use. As Bill said, there are emerging examples, for example, using one of the PARP inhibitors that are very expensive for not just germline BRCA1 or 2, but germline PALB2, emerging evidence at ASCO this year that might be helpful, but that's certainly not on NCCN, for example. But there has to be some consideration and accommodation for the 20%, but I think you can build those budgets. As Bill said, if somebody is kind of way off the reservation and making something up that has no basis whatsoever, well, that's not reasonable. But on the other hand, we have patients where precision medicine will help them, et cetera. And some of these are very costly, but I'm optimistic that we can build these budgets as a team